Sir, appreciate it. We'll give everyone just a moment or two to trickle in. And you all can see my disclosure slide okay?
Looks good.
All right. Looks like we're starting to get a good number. We'll go ahead and get started. Good morning, everyone. Welcome back to Grand Rounds for the Department of Medicine at Washington University School of Medicine. I'm John Hickman, one of the chief residents, and it is my pleasure, as always, to welcome you back. On behalf of our chair, Dr. Frazier, Dr. Costco, and myself, we're so happy you're here to join us. I'm very excited for our talk today. We've got a couple great talks coming up the next few weeks as well I want to make you aware of. We have Dr. Rodman joining us next week. The week after that, our very own ID department is going to give us an update on panel style on COVID and new developments, new therapies, and where we're at. And I want to let you know in a couple months here, about 6 weeks, we're also going to have the director of the CDC, Dr. Rochelle Walensky, joining us. So make sure to keep your eyes out for that. Speaking of exciting talks, we're very happy to have Dr. Lee join us in the University of Chicago. We'll hear more about her in just a moment. Want to let you know, as always, there will be an opportunity to ask some questions. I will moderate the Q&A with our speaker at the end, so please send anything that comes along through that Q&A function or the chat. There'll also be an opportunity for feedback again. I'll have a QR code at the end right next to the CME one. If you need to, please send us your thoughts, what's working for Grand Rounds, what isn't, what speakers you'd like to see in the future, or any topics that we're missing. We'd love to hear from you. Here to introduce our speaker, we have Dr. Abby Spencer. She is the director of the Academy of Educators and our very own vice chair of education. Dr. Spencer, thank you for joining us today.
Sure. Thank you for the incredible opportunity to introduce the amazing Dr. Weiwei Li. She is the associate professor in the section of general internal medicine at University of Chicago Pritzker School of Medicine. Her academic interests focus on medical education research, where her work focuses on developing innovative patient-centered models of care, improving doctor-patient communication, and physician well-being. Her other areas of interest include developing curricula to improve patient-centered EMR use, outpatient clinic handoffs, and physician well-being and resilience. Dr. Lee is also, you should know that she is the mentor of mentors. She is the educator of educators, and truly an outstanding human being who is very dedicated in her entire career and all that she does to making both training and doctoring more humane, to maximize our ability to be our best selves and also to practice outstanding internal medicine and to provide our patients and our communities the best possible care by making sure that we are our best possible selves. So I give her a lot of credit for taking on a really important topic, which isn't just wellness and well-being, but actually mixed messages in wellness and well-being. So Dr. Lee, we're thrilled to have you, and thank you so much for sharing your morning with us. I'll give you the floor.
Thank you so much, Dr. Spencer, for that kind introduction. I only wish my mom was here to hear that. I'm going to go ahead and share my screen. I'm really delighted to be here today with all of you. Thank you for the invitation. And as Dr. Spencer mentioned, I'm looking forward today to talking about mixed messages in trainee well-being and sort of thinking about for us as we move forward into the second year of the COVID pandemic, as we all think about the well-being of our physicians and our trainees, about how these mixed messages can contribute to this culture of well-being at our institutions. So today I'll be able to share with you some thoughts on how to, first of all, identify these drivers of distress in our trainees, and then explore again the impact of these mixed messages on well-being, and then hopefully talk about some ideas about how we move forward and how we can make sure that we're addressing the issues and sending a unified message that really helps us think about our cultures and our systems of practice to improve and enhance well-being for our trainees and for our faculty. So really thinking about the concept of burnout, a lot of what we know in the medical literature around physician well-being and trainee well-being focuses on the concept of burnout, right? We know that it is the state of vital exhaustion and that it is a workplace related syndrome, and it's stress that's not been managed from that workplace, right? So we also have a large amount of data now that shows that as we physicians and trainees move through our medical education system, that when we enter medical school, students have better mental health when compared with their peers. So lower burnout, lower depression, higher quality of life. But unfortunately, this is reversed by the second year of medical school. And the data shows that burnout increases in residency. And then moving forward into life after residency, we know that burnout and work-life balance and dissatisfaction often peak mid-career, so 10 to 19 years into a career. So there's clearly something going on in the way that we are thinking about the culture and education, and perhaps these mixed messages that really contribute to this burnout progression. So just to highlight some of the data around physician burnout, these are large national studies that have been conducted on serving physicians across the country and across specialties. So you can see that physician burnout has remained in that 40 to 50% range over the past decade or so. And we know that it is twice that of other US workers, right? So the mean burnout for physicians across the country, across all specialties is about 44%. And here you can see that for general medicine and other internal medicine subspecialties, we are above that mean, right? So there's a lot of work to be done. So I don't think I need to remind you guys that there are, significant consequences, both for the physician's individual life and personal life. So relationship impacts, impact of alcohol and substance use, depression and suicide, as well as in the clinical world and professional world that we inhabit, right? Decreased quality of care, patient satisfaction, productivity, loss of professional effort, turnover. These are all associated consequences of burnout in our profession. So how does that impact our trainees, right? How does burnout impact medical students? A lot of it plays out in sort of realms of professionalism. So studies have shown that there can be increased rates of cheating and dishonest behaviors, a decrease in altruistic professional values, hard time identifying and managing conflicts of interest, empathy goes down, and then inappropriate attitudes about prescribing have also been identified, right? So real professional consequences for medical student burnout, in addition to, of course, personal consequences as well. And then taking a look at the impact of burnout on residents and outcomes, we do know that studies show that suboptimal patient care and practices can result, as well as increase in medical errors for residents who are burnt out. So taking a look at some large studies that have been looking at this prevalence of depression, depressive symptoms, suicidal ideation. This was a large systematic review published in 2016. And what was found was that among medical students, the prevalence of depression was 27%, with quite a wide range that you see here. And that this is compared to prevalence of depression at about 9% in age-matched population and the general population. And this is certainly, a cause for concern, right? And among medical students who had depression, I think alarmingly, only 16% sought treatment. So that's another area of concern and focus. I think that has a lot to do with some of the stigma mixed messages that we send. And alarmingly, suicidal ideation was found to be about 11% for medical students in this meta-analysis. So what happens when you move along in training, right? So this is a similar study taking a look at studies published amongst residents for depression, and taking a look at that prevalence is about 29%, and that there's a 16% increase in depression symptoms within the first year, intern year of trainings. For us as medical educators, this is something incredibly important to keep in mind and think about how we can address these mental health concerns and distress in our trainees, right? The study found that there were no differences in depression between non-surgical and surgical specialties, and that there were similar rates across these specialties, PGY year and country of practice. This was an international study. I will say that there's not much research published on depression and other mental health prevalence amongst faculty and practicing physicians, not in terms of large systematic reviews or meta-analyses. But if we are thinking about the pipeline, I can't imagine these numbers are much better. It's the same group of people moving through. So this is a real area of concern, right? And importantly, I think it's really vital that we think about physician suicide. It's estimated that 300 to 400 physicians die by suicide each year, and that men and women are more likely to die by suicide who are physicians compared with their non-physician peers. It's also quite known that suicide, it is a rare phenomenon, thankfully, but it's also grossly underreported. So we don't have a lot of clear data on the rates of trainee or physician suicide. And that is, there's some efforts being taken to try and improve what we know about the phenomenon of suicide in our profession. But what we do know is that a lot of the studies that we talked about and other studies show that suicidal ideation is a real concern, and that interns, in the first 3 months of intern year, suicidal ideation increases by 370%. And that in some studies, it shows that for residents, the 12-month rate of suicidal ideation is about 8%. And there are studies looking at practicing physicians and surgeons have a lifetime prevalence of about 15% for suicidal ideation. So there is a lot that we can do, I think, as as professionals, as thinking about our medical education and culture, about what we can do to address these events and to prevent suicides and get people connected to care. What we also know from the literature is that resilience deficit is definitely not the problem, right? Physicians have higher personal resilience scores than workers in other fields. This has been shown in studies. And that about 30% of physicians with the highest possible resilience scores were burned out. So they're not mutually exclusive. It's not like being more resilient can protect you against burnout per se, right? So resilience is something that physicians have in spades to be able to move through training and tough clinical situations and to move forward in this environment. It is not lack of resilience that is the problem. And you cannot underestimate the impact of the COVID pandemic, right, on compounding all of these issues. Many of you are currently working frontline in the hospital through another surge, but this has been a 2-year large-scale stressor on our healthcare system, on our physicians and trainees. And it's vitally important to address at this time, right? So recent studies have shown that when you look at the impact of the pandemic on our workforce in healthcare, this is a large study of physicians and other workers. Close to 40% expressed anxiety or depression symptoms, and 43% felt that there was too much work and too much work for them to be able to handle reasonably. And the physician subset of the sample, burnout, was higher at 48%. Remember, I just showed national norms of around 44% in the last kind of large data set that we have. And anxiety symptoms were present in about 25% of physicians. And these numbers are even higher in residents and fellows in this study, right? So this is the time to move and act on this. I also do want to remind all of us that this stress and burnout is obviously not just impacting physicians and residents, right? At this point, we know that from the last study I was just talking about, that when we take a look at they use this summary stress score for this study, all of our colleagues in the healthcare profession in the hospital are experiencing the stress related to COVID. And our nursing assistants, you can see, have some of the highest scores, medical assistants, social workers. And you'll see that physicians are impacted obviously by a lot of these stressors, but many of our colleagues and team members in the health, in the healthcare world that care for our patients and keep our systems running are experiencing unprecedented levels of stress, leaving their professions, and it's creating more distress for a healthcare system that's already stretched incredibly thin. So that is the context that we're operating in, right? And then really thinking about physician mental health as COVID moves forward. We already looked at those numbers of physician depression amongst trainees and students, and we know that COVID has really exacerbated that as well, right? So the data on physician distress is clear, right? So now where do we go with this? This is just a really great illustration of how much burnout and well-being have become part of the literature and that the data is mounting. So if we take a look at the number of studies published in PubMed on these topics between the year 2000 and currently, there's been a 20-fold increase, right? And that I think just helps us to understand the landscape more and what we can do to address these issues. So the first step is, we're here. We've been at the first step for a long time, right? We recognize that physician well-being is a key priority. Every professional organization has come out and said, we need to address physician well-being, right? The alphabet soup of organizations have put forth recommendations and modules and helped us look at our accreditation and ways that we can build in a focus on well-being into our education system, right? It's been incorporated into the quadruple aim. But it is time to take action. We can't just keep staring at this dumpster fire in the middle of a flood amidst a pandemic and not do something, because I think we lose a lot of morale and trust from our trainees and our colleagues and fellow physicians if we say, hey, here's a problem, but there's really not a lot of focused effort on how to address and meaningfully address these issues. So the second step, okay, now what, right? So building structures to address well-being. So at medical schools around the country, I was fortunate to be able to lead a study recently that surveyed medical schools in the US and Canada. And we found that 93% of these schools had a formal wellness program to attend to the well-being of medical students, right? And I also know that residency programs around the country are putting together their own wellness initiatives. And there's less published data on sort of the prevalence of this, but at your institution, I know there is a robust wellness committee for your residents, and oftentimes these initiatives are folded into institution-wide initiatives as well, right? So this is the second step, building that structure to address well-being. But you cannot just, establish a wellness program or a committee without understanding the context or the framework, right? So this is a really helpful conceptual model to think about. This comes from Stanford and is their model of professional fulfillment, right? So in order to address burnout, in order to enhance professional fulfillment for our physicians and trainees, you need to think about three spheres here, three parts of this circle. The culture of well-being, right, which has to do with leadership support about how much of a priority well-being is at your institution. And this is where establishing wellness programs, having a chief wellness officer, having institution-wide initiatives, this is where that belongs, right? For your physicians and trainees to feel like they have voice and input, that there's a sense of community and appreciation and peer support, right? All of that is around that culture of well-being. And then importantly, the efficiency of practice as well. What is the work environment, the learning environment that we live and dwell in, right? And for our trainees and residents, oftentimes these are stressors related to scheduling or inefficient workflows, documentation burdens, EHR, team-based care. So, these two parts of this model and this circle are actually the largest drivers of burnout. And more data suggests that interventions really need to target this culture and efficiency of practice, that learning and work environment. And that it is important also to address personal resilience, things related to self-care, self-compassion, really helping people think about work-life integration. But the bulk of the drivers of burnout for both trainees and for practicing physicians are around that culture and the work and learning environment and efficiency of practice, right? So building a wellness program or committee, you really need to be able to actually impact also that culture and the learning environment and efficiency of practice to be able to be effective at it, right? Otherwise, you will get a mismatch. If the message you send by having a wellness committee is we value your well-being, we want you to take care of yourself, focus on your personal resilience and your well-being, but you send people off to work in a culture and environment that do not support well-being, that add stressors and additional distress to an already challenging work environment, that is incredibly damaging, I think, to your organization and to the trainees that we want to move forward to become leaders of our institutions and medical education moving forward. So there are mixed messages that are sent from individual faculty members as well as from the organization, right? So when these messages are coming from individual faculty, why is it that these messages are being sent, right? Well, it's because there's often a tension. I think a lot of faculty and senior physicians have mixed feelings about some of these well-being initiatives and curricula and training, right? They're balancing this idea of, okay, yes, I want to support my trainees, but I'm not sure I want to coddle them, right? Or, is supporting them seen as coddling? This tension between, physician well-being and patient care, right? How much self-sacrifice is involved in caring for patients. And it's, a marker of strength, for many to be able to work incredibly hard for patient care, right? And then our residents are clinicians, right? And really frontline essential medical workers, but they're also trainees who need to be, at their teaching conferences and to be able to continue to learn and grow in their craft, right? And then there's also this idea of, well, why do the residents and students have these wellness programs and initiatives and, benchmarks? What about the faculty? No one cares about faculty well-being. Why should I care about trainee well-being, right? And so all of these mixed messages and tensions get built into the hidden curriculum and into our medical culture and continues to erode our efforts to meaningfully address well-being in our system. And so a word on medical culture. I think many of you are familiar with the blog Humans of New York. It's a photo project that was started and it's incredibly popular in highlighting stories of individuals in New York City. And this is highlighting a story of a medical resident. And here he's talking about culture, right? It's a strange culture in medicine. People are less friendly to each other than I imagined, right? He's finishing his residency now and thought that people would be compassionate. And he does work with a lot of compassionate people, but the stress just erodes people. There's a lot of tension and anger. We are taught that 80 hours a week is normal and should not be questioned. But at the same time, there's huge amounts of work that interns do, and that is a lot of it is administrative, and it could be outsourced without affecting the quality of education. And the culture does real harm. I think this is where it's important to really focus on, right? This individual has friends and colleagues who have died by suicide. And I think we all have been touched by suicide amongst our colleagues and peers as well, right? So, I think it's really important to just acknowledge this, right? He is saying here, I can see the end of the tunnel. He's almost at the end of his training, but the tunnel is very damaging. So what is our part in this tunnel as faculty and as physicians in medical education? And what can we do to make sure this tunnel is not, causing, irreparable harm for our trainees in the next generation, right? So we need to address the medical culture, right? Our culture is based on a long-standing history of a hierarchical structure, a real focus on perfectionism, right? Low tolerance for not knowing, for failing, for vulnerability, right? That does not promote growth. If you can't admit mistakes and learn from them, you cannot grow and learn, right? And so that's a major concern. Oftentimes asking for help is seen as weakness, right? There's, a tremendous amount of stigma around mental health still and seeking care, whether that's structural through licensure or at our own institutions, not having the time or resources to seek out mental health care. The idea that the strong work ethic is really the most important, that you work hard and you commit 150% every day for your patients and your and the work that you're doing. And then also generational differences exist, right? How many times have I heard in my training and just in conversations, when I was a resident, we worked 120 hours a week, or you fill in the end of that sentence, right? And we did it one way. Why is this generation having a problem with the way that that's been done? And then the idea of, again, sort of prioritizing patient needs over physician well-being. And then that difference in wellness expectations for faculty, residents, and students. There's no unified message across, how we can address the stress and burnout and improve engagement and well-being for the whole continuum of our students and residents and faculty. So I also wanted to just share some examples of these mixed messages and talk a little bit about how that impacts our trainees. So this is an example about mixed messages that are sent by the organization and from our medical culture, right? This is a blog that is part of the New England Journal initiatives to highlight some training experiences. And this was the chief resident who was writing about her experience about finding out at a noon conference that a fellow resident had died by suicide, and that this was the third resident in their city to die by suicide in the past 2 years. At that conference, this tragic news was announced, and then the residents were expected to return to their pagers and get back to clinical care, right? And so they picked themselves up and the work did not stop. And so how was this message perceived by the residents, right? They felt that if they didn't get right back to work, that they were going to be seen as weak and that they wouldn't be able to, could not feel like they could be in that moment and grieve their friend and colleague and the loss. And that when the program did offer forums to discuss feelings and reactions, the culture was such of not being able to be vulnerable and not being able to share because of fear of retaliation that no one spoke up at these forums that was designed to support residents after the tragic loss by suicide of a colleague, right? So what are the messages we are sending as an organization and culture around caring for ourselves, being able to think about the toll that training can often take on our lives, and even in a tragic situation like this, about suicide and how we grieve our colleagues and be able to support one another in one of these pivotal moments in our organization. There's also mixed messages that we send as individual faculty members and the role modeling we do. And I'm certainly guilty of many of these things. So, I put out a tweet recently to ask medical educators on Twitter to share different examples of mixed messages that we send as faculty to our trainees, right? And I think we got a lot of really good responses. And so one of them is around, the fact that we often project that we have it all together. We don't often discuss challenges in work-life integration, right? So faculty not talking about having a family, the challenges of finding, quality time with spouse, varying schedules, the difficulty in conceiving and starting a family that we know, impacts a lot of our trainees and faculty and physicians, right? Breastfeeding, staying awake, dealing with childcare, all of that, right? So not being open and sharing those challenges is saying that, just it's easy and you should be able to do it, right? And then the also projecting the idea of working all the time and being always available, right? Responding to emails late at night on weekends and on vacation, appearance of always having to be available, right? So I think just, there's a lot to be said about what's read from, trainees getting emails, while you're on vacation or late into the night, that sort of thing. And then also, in this culture of Zoom and just working all the time, how many of us have been overcommitted? This is a post about just doing simultaneous Zoom meetings, right? 3 at a time, and wondering, whether this is sending our trainees the idea of, this is normal, that this is the workload that you should expect, that, that it's really hard to have boundaries and to say no, and that you should take it all on, right? So what do we do as individual faculty to role model? And what mixed messages are we sending by our behaviors? Other examples that came through on Twitter, expecting trainees to always know the answer or fake it, right? So we need to be better about applauding trainees for saying, I don't know, or knowing when to ask for help, and role modeling that ourselves, right? And then overemphasis on confidence is another interesting one, right? I think oftentimes the feedback that we give residents is around, okay, just be more confident, right? And that this often ignores the strengths of our introverts and can devalue this humility in medicine, right? So this idea that confidence is sort of the overarching trait that you need to project. And again, that goes with that, work ethic, that ability of, for being perfect and knowing everything. This, I think, really sends a mixed message around not being able to ask for help and not being able to engage in that growth that we want our trainees to engage in. And then there was also a real interesting comments around the culture and about the idea of cutting each other down, right? This idea of bad mouthing other specialties. Trainees hear this as they rotate through different services, and this contributes to this hidden curriculum and this mixed messaging and causes significant effects on well-being. And I've certainly been guilty of multiple parts of this mixed messaging. So I think that it's important for us as individuals to think about how that speaks to our initiatives on well-being and saying that we want that to be a priority. And then lastly, this is really around some of the ideas around work ethic and self-care, right? This idea of it's important to take care of yourself and stay home if you're not well, right? But this can sometimes be viewed as being weak or lazy if you take a sick day, not wanting to jeopardize a colleague, someone else is going to have to do the work that you were not able to do. So not having those systems in place for very predictable life events, like you getting sick, like your child's daycare being closed because of a COVID exposure, being human and needing to take care of our health and our families. We don't have a system in medicine where people are not being pulled from their busy lives and otherwise downtime to cover. And we need to address that. Those systems are not in place, right? So that idea of being strong above all else and showing up as being what is celebrated, I think that really erodes well-being and contributes to distress, right? And then we tell residents be well, right? But then we expect you to work your tail off and to really commit again that 150%. I think more and more institutions again have wellness programs, wellness committees are appointing wellness champions, institution-wide initiatives. So yay, you have that institutional focus and sort of discussion around that being a priority. But if those positions and committees and individuals who are working on this are not supported and given resources to be successful, it is not going to make a change, at the institution that we want to see, right? So that again is a mixed message. Okay, well now you have a wellness champion, and without sort of the authority and the resources to make a difference, it really is more harmful to the institution long term. So what are the consequences of these mixed messages from the organization, right? Well, our faculty, our physicians work in the same unhealthy work environment, right? And so, dealing with these systemic stressors, organizational drivers of distress lead to faculty being burned out, professionalism lapses, mistreatment of trainees or others in our work environment. And then for our trainees, what happens is that they then become more burned out, right? They lose some trust and hope in our system, become more cynical. And then, there's attrition, right? How many of our trainees are going to choose to leave medicine because this is not the work environment they want to be in, right? And then, this last blurb here is from a blog that speaks to this, right? This was a trainee writing about, this is a trainee talking about speaking with other residents about what it's like to be in training and to think about finishing, right? They fear that the light at the end of the training tunnel is dimmer than they expected. I don't want to live the life my attending lives, right? So many of them seem miserable. Their lives look like more of the same, and it's unsettling to think that many physicians delay being happy, right? That delayed gratification, only for the promise of more unhappiness, right? So when we say that wellness is a priority, but we're not able to implement the cultural and structural changes to improve the experiences and well-being of faculty, of trainees, it doesn't seem like there's, the next step is not always better, right? And so we need to really think about making these changes systemically and across the institution. So to address these mixed messages, we really need to align well-being, right? The messages we have around well-being with our culture and the learning environment, and to be clear about what expectations we have related to the work and the workload and the structures that are in place, to have policies that really allow our trainees to attend to their health, and to actually have leadership buy-in and resources available to support these initiatives, right? And we need to focus on those systematic contributors and less on personal resilience. So, thinking back to that Humans of New York kind of focus on the resident, the tunnel is very damaging, right? The tunnel that we know where we have entering students who have really good mental health and quality of life indicators, and moving them through the system of physician education and physician practice with extraordinary rates of burnout and work-life dissatisfaction. We need to think about that tunnel. Okay, and so I think part of it is then reframing. So how can we address these issues meaningfully? How can we promote joy and meaning in a career in medicine for our trainees and for ourselves, right? How do we address these mixed messages? So there's a lot of data and studies out there, a lot of different models that have been put into place to think about how to instill this joy in practice. And a lot of this goes, around that Stanford model as well, right? We need to address the organizational systems. We need to have leaders that really buy in and really have the resources committed. We need to build community and remove some of the inefficiencies and frustration, right? And so all of these things are incredibly important. And then this is another model that exists around physician burnout engagement that really helps to drive down on the individual drivers of burnout and distress, right? So that we need to look at whether, at your own institution, which of these drivers are the most challenging and contribute to distress and burnout, right? Is it workload? Is it efficiency? Is it control and flexibility in your work life, meaning and work, values, social support, work-life integration? All of these dimensions and drivers, if they're less than optimal, can lead to burnout. But if we're able to address the ones that are really most challenging for our institutions, that can lead to engagement and vigor, right, and absorption. So, there are models in place to help us understand where we need to work as institutions and cultures and systems to address this. And a lot of this work has been targeted around practicing physicians and faculty, right? So what about for students and resident well-being? Well, the parallels are there, right? We need to address the learning environment and this culture of well-being and individual resilience, right? And the focus really has to remain on the learning environment and the culture of well-being. So there have been some earlier conceptual models that have been put into place to think about student wellness, right? And how to promote resilience and prevent burnout. So this was one of the earlier models from 2008, where student reserve and ability to deal with stress and cope is kind of seen as this tank. And there's some positive inputs that we can help to strengthen this reserve with support, community and social activities with strong mentorship, intellectual stimulation. And then there are negative inputs that really detract from this ability to cope with stressors, right? Sort of large amounts of stress, internal conflicts, work-school balance, that kind of thing, right? And so depending on the individual's ability to manage these stressors and the inputs that are coming in, again, either students are able to become burnt out or maybe emerge with more resilience, right? But I do think that what this model really is missing is this idea of that culture and that structure again, right? So more specifically. So this is a study that our research team here was able to conduct on medical student wellness programs across the country and across Canada. And what we found was that, again, most schools, over 90%, had wellness programs, and that many of these programs are structured around these core elements, right? This is the framework, right? There are a lot of preventative initiatives to, again, bolster that personal resilience, to think about self-care, to think about importance of sleep and healthy eating and meditation and a lot of those things, right, for those individual factors. A lot of the programming on well-being for students is also around reactive programming. Okay, we've identified students who are struggling with burnout or mental health concerns. How can we connect them to resources? How can we make sure we have the adequate resources to support distress when it arises, right? But then also the focus on the leadership, the culture at an institution around well-being, and again, these structural drivers of distress for students, which often relate to the curricula and the learning environment, right? And these are the key areas that really need to be focused on. And when we surveyed these programs around the country, there was adequate initiatives and programming and workshops and training for the preventative and reactive piece, but the cultural and structural pieces really are lagging and need additional focus. So what would some of these curricular drivers of distress look like, and how can we address them, right? We think about lack of control and flexibility in a lot of our students' schedules, thinking about grading and evaluation systems, thinking about a culture of competition, disorganization in the structure of clinical rotations. A lot of this is baked into curricula. And so in order for these wellness programs at medical schools to be effective and impactful, there needs to be real partnering with our curricular leaders as well to work on this, right? So, here are some of the responses that can be helpful: pass-fail grading, peer support, debriefing sessions to really think about the challenges that emerge in doctoring, right? A lot of this work can and has been done at institutions around the country to address student distress. And then, the AMA has put together modules to think about how to minimize burnout and improve mental health amongst medical students. So I welcome you to, check it out on their website. These are their steps forwards modules, right? So really being able, again, to do a lot of the things we talked about, the curriculum, measure well-being first. You can't change something unless you kind of have a sense of the measurement. So surveying your students, focus groups, understanding what, how much burnout there is at your institution, what other distress is going on, what those drivers are. Student debt is a huge part of this as well. That's a major stressor for well-being for our trainees. And then the environment and culture, promoting self-care and resiliency, that individual piece plays a role. And then there's focus on adequate services for those who are affected by burnout or distress. And then the need for organizational science, right? So I'll speak a little more to those last 2 points. So individuals really need to take proactive steps to identify students in need of services. And this is because there's so much stigma around mental health. There's fear from our students that if they seek help, this will be on their record. They won't be able to match at a residency program. It'll impact them professionally if they acknowledge depression or anxiety or other mental health stressors and get help, then they feel like their careers are in jeopardy, right? So we need to be able to identify the students who need help and make it safe for them to seek care. And that's a huge culture change we need to make, right? We need to provide barrier-free access to mental health care that's accessible. We need to have these policies in place that students can be excused to seek the care that they need for their health and mental health, and that they're not going to be penalized within these programs for seeking mental health services, right? So this is all work we can do as leaders of our medical education programs. And, from the study that we did on wellness programs around the country, it was really heartening to see that most of the wellness programs actually had dedicated mental health professionals just for the medical school, just for their students to address these mental health concerns, right? To take down those barriers. And then the mean FTE per student was, the mean FTE, for these healthcare professionals in mental health were 1.6. So there was, staff that was available to address mental health for our students. And that 89% had optional mental health appointments for their students, and 7% of these schools actually had mandatory kind of check-in appointments for a subset of their students. So again, we need more research. So just because the wellness programs are in place, it doesn't mean that we know if they are effective at medical schools, at residencies, and for faculty, right? So there need to be more interventional studies that focus on these organizational, structural interventions about how to work on the learning environment and that culture, and to be able to study the impact of these well-being programs to know if we are making a dent in our well-being of our students and residents and faculty as well, right? And then thinking about resident well-being, how do we break down these mixed messages? How do we improve the culture and the environment? This is a really great study that was published recently, and it was amongst a cohort of surgical residents, right? They created this conceptual model also around the drivers of distress for surgical residents and how that relates to the learning environment. So many of these will look familiar, right? We just talked about efficiency, culture, work-life integration, all of these. The new elements that they wanted to highlight for resident trainees and well-being are the faculty relationships, resident camaraderie, and mistreatment, right? So for faculty relationships and engagement, it's really vital, I think, for residents in training to be able to have really strong working relationships with their attendings, and this has a significant impact on their professional development and their training experience. So what can programs do? Programs can promote and reward mentorship, right? Actually provide mentoring training for faculty members, and then elevate faculty role models, like recognize and promote these individuals who create this positive relationship and culture for your trainees. And then to see there's a culture of teamwork and appreciation for our residents and the work they do, right? These are the things can really bolster those, this idea of faculty relationship engagement. And then resident camaraderie, right? Is your program fostering collegiality? Do your residents cooperate and count on each other to support each other in difficult situations? Is there psychological safety amongst peers, right? To be able to ask for help when they need it, and is there support, for them in a learning environment? And then mistreatment, was part of the resident model as well, right? Mistreatment is a present part of our medical education system, and it's unfortunate, right? A lot of it is driven from the hierarchical nature and the power differential that's intrinsic to our training structure. And mistreatment can come from many directions, right? Faculty, staff, patients, families, right? And in recent studies that have been published, about 50% of residents, and surgical residents in this case, who experience mistreatment, these people were more significantly associated with having burnout and thoughts of attrition. So 50% of residents reported mistreatment, and of those, they were more likely to experience burnout and then thoughts of attrition and suicidality. So mistreatment has a strong connection with burnout and other adverse outcomes. And then we need to really pay attention to the workload and job demands for our residents, right? So the idea about work compression. Yes, we have work hours. Yes, 80 hours a week is still a lot of hours to expect our residents to work. But there's more complicated care of patients that's happening. There's pressure to shorten the length of stay. There's these increased work demands. So that compression is a major challenge, right? So programs, can think about monitoring and addressing these more proactively. What about the duty hour violations? Who are the individuals that are not able to leave in a timely way? What support do residents need to be able to meet on their duty hours? Is there pressure to underreport hours, right? Are your residents spending time outside of the work that they do in the hospital to finish clinical care? And we have the technology and the data for a lot of this to be able to help us drive interventions, right? Our EHRs can tell us the hours that residents and physicians are logging in that are outside of traditional work hours. And this can help us understand a little more of what's going on with that. And then, we need to support our residents in fulfilling these obligations. So we need to adequately staff our hospitals with personnel, right? So this goes for, clinical staffing, OR staffing, knowing again that, as humans, the residents will get sick and will experience personal issues that need to be addressed to take time off. And so we need to have a jeopardy system that doesn't only rely on other stressed out residents to kind of fill in on these obligations, right? We can think about reducing documentation burden. There are examples around the country. For example, at University of Colorado, they really were successful at implementing team-based care for their family medicine residents and expanded the roles of their medical assistants to act as scribes and assist with documentation and admin support. And they were able to have more time for patient engagement as residents, improve quality of care, and decrease burnout rates by 50%, right? So what are the resources being invested to support our trainees to be able to address burnout and these burdens? And also just to highlight some of the other ways to address burnout. So again, in residents. So again, taking a look at that model from the surgical study, what are the drivers at your institution? If you identify them, there are a lot of great interventions and strategies that can help improve, work of, the control of work, reduce workload, aligning values, addressing moral distress. This is the type of work that, your chief residents and your wellness leaders are probably doing already, right? Is to understand what those drivers are for your particular institution, and then finding ways to address the system and culture to improve those issues that arise. And I do also want to highlight that there are different factors that we can take into account to really reduce burnout and distress. And this is actually from a study looking at depression symptoms in medicine residents. And what they found was that, being able to support our residents who have families, who have children, providing parental leave is vital to reduce family conflict, but also providing daycare, especially in the pandemic, with that being unpredictable. Flexible work schedules, right? EHR, more medical assistants, scribes, PAs, and we already talked about that type of support. So there's a lot of data that mounts around this. And I do also want to end and kind of pause around this idea of addressing mental health and stigma, right? So this is vitally important. With depression rates in medical students and residents that has been well documented over decades of research, to be incredibly high, 30 to 40% range. We need to be able to openly talk about mental health and to decrease that stigma. And there have been incredibly bold leaders who are doing this, right? So Daryl Kirsch, who used to be is the president emeritus of the AAMC, has spoken openly about his own journey with mental health and depression at the AAMC national meetings and has written about it in academic medicine, right? So, his piece about physician mental health and his own journey was actually part of a larger issue at academic medicine focused on mental health and focused on burnout and distress for our profession and for trainees. And so in that article, Dr. Kirsch talked about this idea of experiencing anxiety and depression in medical school and feeling like he had to keep that incredibly private, right? And that if he acknowledged those challenges, he felt that he would be lessened in the eyes of his colleagues and patients and friends, right? And that he recognized that speaking up, especially from a leadership position about his own personal adversities and challenges related to mental health, empowers others to do the same and reduces the shame and stigma associated with mental illness. There should be no shame and stigma associated with mental illness. This is not what we want and tell our patients. This is not what we want our residents and colleagues to be struggling in silence, to not get the help that is available for completely common and medical conditions that have effective treatments, right? So we cannot have people suffering in silence, right? And so, Dr. Kirsch put out a call that we in academic medicine have to examine our cultural and organizational factors that promote burnout, distress, and what is it that is limiting help seeking, and really change those issues and concerns. In that same issue of academic medicine from last year, there was also this great study about how individual interventions can really think about destigmatizing mental health. And this was a study done at Mayo and their training program, where they had 3 self-selected faculty members come share about their personal experiences with depression and mental health at a noon conference. And they provided mental health resources, right? And they found that of the attendees, 89% agreed that knowledge of mental health resources increased. So this gets the information out there about where your trainees can get help. 84% agreed that they were more likely to pursue those resources after attending this session. Almost all agreed that faculty sharing personal struggles destigmatizes mental health issues during training, and that almost all of them engaged in reflection of their own mental health and well-being. And this is just after one noon conference, right? So this is all within our scope of control and what we can do as educators to address the stigma, around mental health. So we can't just say, take care of your mental health and not provide a safe culture and access to resources. And that mixed message is incredibly damaging. And I think we do have some control over that, right? So at our medical school here, I do direct our wellness program for students at Pritzker at the University of Chicago. And we have a mental health panel that is by far our most valuable experience for students around mental health and well-being in their first year from the feedback they've given us. So, we've held this annually since 2015, and I invite a panel of faculty physicians who are often well known to the students and role models and leaders. I invite residents, I invite senior students to share their stories of mental health journeys, of depression, anxiety, OCD. We have just an incredible array of experiences that we are able to share about how it is that people have navigated these challenges and sought care and move forward in their careers extremely successfully with the right care and support, right? And it's a required event for all our first year, so everyone is at the table. We set the culture and tone that this mental health is incredibly prevalent amongst mental health issues is incredibly prevalent amongst medical students and throughout their training. And we talk about licensure and the challenges there. And then we also talk about, the resources available. So these are all things that we can do at our institutions, right? And then we do need as a profession to advocate for medical licensure changes, right? Because there are some states that still require reporting any mental health diagnosis to boards. And this really invokes fear in our physicians. They don't want to seek help. We don't want to seek help, right? Because we don't want any restrictions on our medical license. What impact does that have on my ability to care for patients, right? And so, the Federation of State Medical Boards has been working to try and advise states that, they should only be asking about current issues that undermine a physician's ability to work, right? That impairment, and that the other questions, violate the ADA. And so really continue to advocate and push for these changes on the licensure board can really change those mixed messages from that organizational and national level. Great, and then removing barriers. So opting out of mental health, right? Opting out of mental health care as opposed to asking people to seek out the care when they need it. There are different pilot programs that have found this to be effective as well. This is from the University of Colorado for their medicine and med peds programs. Interns had a half day for mental health screening appointment that was made up for them. The whole program only cost them $11 per intern. What they found was that 30% attended appointments. There were people who opted out in advance, about 56%, and 15% were no-shows. But this puts a system in place so that residents are not trying to build this into their busy schedule, and hopefully people who want to seek help or just check in are able to do so, right? So I'm just going to leave with these thoughts in that, it's great that we have prioritized well-being for trainees, but we cannot do that in isolation. We need to focus on our culture and our work environment as the ways forward to stop sending those mixed messages around just powering through and taking care of your own well-being while working in a culture and environment that really detract against that. So for us as faculty, what we can do as individuals is create that psychologically safe space for our trainees to be vulnerable, role model our own vulnerability, share our experiences, reward asking for help, admit when we don't know something, and being transparent about our struggles and tensions and having those healthy boundaries, right? And so I'll end on this. We all went into medicine as salmon, right? We knew that we would be, swimming upstream and there'd be challenges along the way, and we were happy to accept those challenges, right? But we cannot have a system where you are swimming upstream as a salmon and having 3 bears trying to eat you along the way, right? Like, we need to remove those bears and jumping up against waterfalls and just be able to decrease the organizational and structural drivers of distress that are creating incredible amounts of burnout and distress amongst our trainees. And we need to make sure that tunnel that we have is less damaging, right? And to give our trainees a sense of next steps in addressing and prioritizing their health. So I'll end there and just want to thank all our trainees who are here today and all our faculty educators who I know are working really hard on these issues at our institutions. So thank you.
Dr. Lee, thank you. Thank you for joining us today, and thank you for presenting your important work in this talk. Let me go ahead and quickly share my screen while I get to some questions, because I know a lot of folks have them. Okay. One question, hoping you could address for us. Can you comment more on how systems like what you brought up from Colorado may influence trainee sense of meaning at work by focusing on being a true clinician? They say, I wonder if improving sense of meaning at work would have a protective effect against burnout from the various factors contributing to our current state.
Yeah, absolutely. I think there's a lot of data being published on team-based care, team-based documentation, documentation burden being a major stressor, especially for our physicians who practice, a lot in outpatient primary care fields, right? And so I think having scribes and documentation assistants in place allows our faculty and trainees to form more of a connection with their patients and to be more present during those visits. I know we've done studies, pilot studies here at University of Chicago with faculty and scribes. And what we found was that within the first month of implementing a scribe, our senior physicians were telling us, this is the first time I was able to sit down and focus entirely on my conversation with the patient in the, first time in 15 years I've been able to do that. And so I think that does drive that patient-doctor relationship, that ability to connect with patients does drive that sense of meaning for our faculty and trainees.
Thank you for that. We've got a couple, which are, I think, more comments at this point about how necessary it is for state medical boards to, with the disclosure of mental health conditions, what a barrier that is to, feeling safe in that space and being able to disclose and talk freely about mental health problems and the stigma. So it looks like most folks agree that, boy, that needs to change. And thank you for bringing that up.
Yes, no, I really think that is within our sphere of control. We as individuals, whether you are a student or a resident or a senior faculty member or, the CEO of your hospital system there, I think that the more that we can role model and be open and vulnerable and comfortable in sharing our own experiences, I think that does do so much to change the culture and the conversation around mental health. And I think it's attainable, in our local environments.
I think that the issue of advocacy has come up a few times in questions here. One from one of our attendees says one of these issues comes from the lack of this physician advocacy. It's led to a lack of control in the work that we do. They give an example here of how physicians are being asked to volunteer for extra COVID coverage without any compensation, while other professions are receiving compensation for their time. Such inherent expectations are burning out our doctors. What can we do to advocate for ourselves?
I think that is incredibly important. That speaks to not feeling valued at your institution, to not feeling respected, to not having it acknowledged about how you are expected to step up. Work 80 hours a week, and then you might be jeopardized next week to cover the ICU because one of your colleagues is experiencing COVID, or other things that are happening. So that is a major issue that drives distress and burnout. And I think that being able to point at that from, an equity perspective, but also, I think we do have more leverage at this point than at other points in time for burnout. At the end of this pandemic, whenever that may be, we are not there yet. But, these are unprecedented rates of burnout, right? Over 50% in many institutions. Now we're working in an environment where we don't have enough staff and support, which we know drives burnout. And so I think issues around that compensation and that, idea of bringing in other people to step up because our workforce is exhausted. I think that advocacy from your faculty leaders, from your residents and other trainees, I think that needs to be really addressed.
Yeah. You talked about the importance of community as a protective and helpful in avoiding burnout. Do you have any best practice ideas for how can we foster community in particularly our current climate where staying away from each other and social distancing is so necessary at the same time? Are you aware of any way to do that successfully?
Oh, that is such an important question. It's something that we are thinking about and struggle with. When everything went remote with COVID, it is really tough. I mean, even for myself as an educator, I used to really value the small group teaching sessions with our interns and our residents, and doing it over Zoom. It's talking to, a lot of black boxes, and it doesn't feel like I can get at those, conversations that would happen organically before we started. How are things going? Tell me what's going on. What can I help with? Like, you seem stressed today. Like, can I check in on you? Right? Like, so those human interactions that happen in the environment and background of our lives are not happening. So I think there needs to be more, focus and outreach. I think fortunately for us, much of our work still happens in person, in clinical care. So whether it's in the clinical spaces or in the, inpatient side, what are the structures that are in place to provide either peer support, that additional mental health support. So being proactive, being able to debrief, with our trainees after really challenging blocks and losses and issues that come up. So having that structure in place, but also proactively, having faculty who are in education be checking in on residents that they work with, residents that are rotating on really challenging rotations currently. There can be things that can be helpful.
There's one or two more questions, but I think in the interest of time, we probably have to say goodbye and thank you. So thank you. We really do appreciate it. It is a very pertinent and important topic, particularly with just what the state of the world right now. So thank you for sharing your expertise and joining us today. It means a lot.
Thank you all for having me. It was a pleasure.
All righty. Well, thank you everyone for joining us as well. And please join us again next week. And if you have a moment, please scan the QR code and provide some feedback about the Grand Rounds experience. Thank you, Dr. Lee.
Thank you, everyone. Have a great day.
Thank you, Dr. Lee.
Bye, Dr. Spencer.